Hello friends, when both the femurs are fractured, it's kind of an emergency. Because of the ongoing blood loss, the patient may end up in hemodynamic shock, or sometimes there is excessive risk of fatalism because of the two long bone fractures, and these issues are associated with high mortality in these patients. So the timing is crucial. You have to go for early stabilization of these fractures, and the surgical duration is also critical. You can't go for a long duration surgery in these patients because if surgery is prolonged, the hemodynamic stability of the patient may get compromised further. Now you can go for intramedullary nailing of both the sides if the hemodynamic stability is not compromised, or you can go for one side nailing and external fixator on the other side depending upon the overall hemodynamic status of the patient. And sometimes because of the limitation of the time, you have to go for external fixator on both the sides because your purpose is not the definitive fixation of the fracture at the initial presentation. Your purpose is to save the patient, and it can happen with any kind of stabilization in the initial period. So as I told you, the surgical duration is critical. Some of the residents had asked me, how can we save the time during the surgery so that we can go for intramedullary nailing of both the sides in a short period. So on an average in our setup, we take around 1 hour for intramedullary nailing of both the sides because we avoid wasting time in the repositioning of the patient. What we do, we either operate the patient in supine position with draping of both the limbs simultaneously, or we take the patient on a fracture table and keep the post centrally. Then we keep the limbs in the scissoring position like this. You see, one side is lifted up while the other side is down. So if we want to operate the right side first, we'll elevate the right side first. And when we are done with the surgery on the right side, then we'll elevate the left side. So that will not affect the draping. You simply lift the limbs of the fracture table up and down, and that will help you in the position. So that will help you in the position. And we have to drape till the umbilical. So the gluteal area and the area near the iliac crest is quite visible, so that making entry is not difficult, and making entry in the coronal plane is not an issue. You simply adduct the operating side while abducting the opposite side. So if you are operating on the right side, you simply adduct this and abduct the contralateral side. The arm has to be adducted and flexed on the affected side so that you get enough space for making entry, reaming, and inserting the nail. The opposite side arm can be kept in extended and supine position, so that is not an issue. And when we operate on the other side, we simply reverse the position of limb and arm like this. We make the left side arm adducted and flexed, and we get enough space for making entry, reaming, and nail insertion on the opposite side as well. The issue lies in making entry, reaming, and nail insertion in the vertical plane. You have no clearance of the gluteal area from the underlying surface. So this area may actually block your working hand. You may face difficulty in placing the guide wire, reamer, and nail because of the edge of the table blocking your space. And also the lateral view will be difficult because the contralateral hip will be coming in the way of the affected side. So what we do? We simply place two bolsters, one thick bolsters on the side which we are operating, and one small bolster on the side which we are yet to operate. By that, we get enough space near the trochanteric region for making our entry, reaming, and nail insertion. Like here you see the bolster has been placed under the gluteal area, and because of that the hip is lifted. So we have enough clear space for placement of the guide wire and doing all the procedures which we normally do for femur nail. And also, as you see here, the lateral view is not an issue because the contralateral hip is lying at a lower level. So you get a good fluoroscopic view of the affected side. Like here you see, we are inserting the guide wire without any difficulty in the lateral view. And when we are operating on the other side, what we do? We simply remove the first bolster. That means when we are done with the right side, we simply remove the right side bolster, then automatically the opposite side hip joint is at a higher level because of the other small bolster. Now with that, we are able to get the lateral view of the opposite side as well, like here you see. And also the clearance is also there because the table edge will be lying somewhere here, and it will not be hindering the area where you want to enter your guide wire, reamer, and nail. So that is not going to be an issue. So by this procedure, we are able to do our procedure in a short duration because the most critical time is the time which we waste in the positioning. And by keeping the scissoring position, we are actually preventing that. The reduction of the femur can be done by the conventional means. The most common issue that we find is that the proximal fragment is often flexed while the distal fragment is often extended. You can use an F tool. You can simply place a bolster here to add flexion at this fracture site and then pass the guide wire. Usually in the coronal plane, there's not an issue because of the fracture table, and sometimes the assistant can also give the traction, so that is not an issue. But here This deformity, that means the proximal flexion and distal extension, has to be corrected by other maneuvers. Sometimes your assistant can push this fragment downwards and pull this fragment upward. That will also align the fracture in its position. But one thing you have to take care of is to avoid wasting time. Suppose in a muscular patient, if you are facing difficulty in reduction, do not waste more than a minute. If you are facing difficulty or you are not having access to the F device, you simply go for a small stab incision, and that is sufficient enough for placement of a long curved artery forceps or a curved coccus forceps. The concern regarding loss of hematoma is just a theoretical concern. Just by losing few drops of blood, the fracture healing is not going to be compromised, and the small stab incision that you have put is eventually going to heal without bringing any sockage, because automatically the soft tissue will approximate on its own because of its own tension, and that is not going to hinder the healing process at all. Like here you see the patient was a muscular one and we are not having access to the F device. So what we did, we simply placed an anterolateral stab incision, and through that stab incision we simply passed a curved artery forceps like this. The artery forceps glides along the lateral surface, goes posteriorly while keep touching the bone, and then simply lifts the fragment up. So it's just a few seconds work. When the timing is critical, that small stab incision is not going to compromise your healing. You simply place this artery, lift the fragment up and pass your guide wire. And this is a clinical picture. You see how small incision it is. And this is the picture after 2 weeks. It eventually heals without any problem. It's not like that it is going to leak the fracture hematoma completely. It's a small incision, and once the artery is removed, it approximates on its own. Or you can place a deep bite suture also if you have any concern. But as I told you, the timing is critical, so you can use this maneuver also. It is not going to affect the healing at all. So these are the basic tips which we use in these fractures when the timing is crucial, and that actually saves us a lot of time. And the patient outcomes are definitely good as the surgical duration is obviously short. So if you have any queries or concerns regarding these tips, you can just ask those in comments. Thank you.